Now we're going to show you examples of pathology of the heart, myocardial infarction, ventricular aneurysms, intracardiac thrombosis, septal rupture, mitral calcification, and intracardiac filling defects. Heart attacks can be detected by magnetic resonance imaging with and without the use of a paramagnetic contrast agent. One can see the high signal in this region of the left ventricle indicated by the arrow in a patient with transmural myocardial ischemia. It is the edema of the wall of the ventricle that produces the high signal as well as extravasation of blood. When injecting a paramagnetic contrast agent, we can accentuate the abnormality. It's indicated in the right picture of this case that had a myocardial infarction involving the anterolateral wall of the left ventricle. This is a diagram which shows the effects of a heart attack when a ventricular aneurysm occurs. When there is a true aneurysm, we can see all the layers of the heart represented, and there may or may not be a mural thrombus associated with it. When there is a false aneurysm, there is a rupture of the heart, and then we can see that the wall of the heart is formed by the blood clot and the pericardium. Women have more than 70% greater risk of death than men after a first myocardial infarction. Almost 4% of patients admitted for acute myocardial infarction die of free wall rupture, and this rate appears not to have changed during the past 16 years, while overall mortality of acute MI has decreased dramatically. Myocardial rupture is 3 times greater in frequency in patients during the first acute myocardial infarction than in those with a prior infarct that healed. The greater risk is believed to occur because the shearing effect of muscular contraction against an inert and stiffened necrotic myocardium is far greater than in a heart with healed scars from previous MI. This situation is exacerbated in the presence of hypertension. When a left ventricular aneurysm develops radiologically, we may be able to detect the calcification in the free wall of the left ventricle, particularly around the cardiac apex. However, the majority of left ventricular aneurysms are not detectable by radiographic techniques. That means frontal, lateral, and even oblique views of the heart due to the fact that the apex of the heart may be obscured by the left dome of the diaphragm unless there is a calcification. The second image is a CT of a left ventricular aneurysm where you can see uniform calcification in the contour of the left ventricle. Then we see a photograph of the specimen showing the pale surface of the left ventricle. And finally, a radiograph of the specimen showing the heavy calcification that was seen in the wall of the left ventricular aneurysm. These are 2 cast corrosion preparations of 2 patients with a left ventricular aneurysm. In the first cast, note that there is barely no red at the level of the aneurysm. However, we see abundance of blue veins. That means that the vascular supply of the left ventricle was affected, but not the venous circulation. In the next cast corrosion preparation, we see the filled left ventricular cavity with barely no vessels in its surface. This is a CT of a left ventricular aneurysm in a heart that shows diastole on the left and systole on the right. And note the hourglass deformity of the left ventricular cavity and the diffuse hypokinesis, or actually akinesis, of the periapical portion of the left ventricle with marked diminution in the ejection fraction. Here we can see the MR of a left ventricular aneurysm, again showing in black the cavity of the left ventricle, which has an hourglass deformity. Note the marked thinning of the periapical portion of the left ventricle. These are sequential cross-imaging sections of the left ventricle that had an aneurysm. And note that in the lower cuts, we note the hourglass deformity of the left ventricle and the akinetic periapical portion with marked thinning of its wall. In the next one, we can see the aneurysm of the left ventricle with the chambers opacified. Note that the septum appears normal, but the periapical portion fails to contract due to the presence of the apical aneurysm. False aneurysms of the left ventricle can be the result of a heart attack or trauma. This is a diagram of a false aneurysm where its walls are formed by the clot and the pericardium. That's why they're so vulnerable to rupture. In the next one, we can see an MR of a false aneurysm of the left ventricle, which tends to occur in the dorsal or diaphragmatic aspect of the left ventricular cavity, in contrast with the true aneurysms, which are typically located around the apex and free wall of the left ventricle. The next is the angiocardiogram that corresponds exactly to the anatomy seen in the MR study, where one can see the aneurysm in the posterior aspect of the left ventricle. And finally, we see another case of a rupture of the left ventricle occurring in the dorsal aspect of the left ventricular cavity. In addition to left ventricular aneurysms, thrombi can develop in the aneurysmal cavity, as illustrated in this CT study. The filling defect is noted in the periapical region. These masses can embolize, and systemic arterial occlusions can occur as a result of free-floating thrombi inside the aneurysmal cavity. In the MR examination of this other patient, we can see the high signal that corresponds to a thrombus inside the aneurysm. Thrombi can occur also at the level of the right ventricle, as indicated in this sagittal image. On the MR, the high signal corresponds to the thrombus in the vicinity of the right cardiac apex. Finally, another complication of a heart attack can be a ruptured septum. And note the lower part of the interventricular septum that is missing. This is a left to right shunt condition due to a quite large ruptured interventricular septum, an acquired VSD. These are two examples of heavily calcified mitral valves. Note the density that is quite extensive, indicative that the annulus of the valve was affected and the calcium infiltrated the muscle. Calcified mitral annulus are quite common in elderly individuals and most of the time are asymptomatic. However, we may see arrhythmias and even chest pain as a result of extensive calcifications that involve the myocardium. Filling defects within the heart are commonly seen in contrast studies when we do computer tomography. The first one is a typical myxoma of the left atrium. The mass protruded into the left ventricle during diastole and went back to the left atrium in systole. These masses usually arise at the level of the interatrial septum close to the mitral valve. And in the second case, we note rounded filling defects that represent a four-headed papillary muscle. This is of no clinical significance.